Welcome, Health Impact audience. Today we've had a really great day in which we've had a lot of discussion around the difficulties that the health systems and clinics and everybody in the healthcare system is facing as far as workforce challenges are concerned. And then we started talking a little bit about how do we accommodate the new requirements around digital and other technologies so that we can bring our workforce up to speed in those new technologies, but be also ready to take on new things that are going to come up over the next 6 to 12 months as well. So for that discussion, we're seeing that the healthcare systems are changing pretty rapidly. The question is, are they changing in the direction that we want them to change? To have that discussion, we've assembled a great panel, starting with Karen from Geisinger, Chris Ross from Mayo, John Holemka also from Mayo, and Peter's going to introduce himself in a minute as well. But what I'm going to do first is to set up a series of questions around where we're heading as far as our innovations are concerned and whether the direction is correct. Then we're going to start talking about, well, if the direction is correct, how do we double down on it? If the direction is not correct, what can we do to adjust? So that's where we're really going to start. And so first, I'd like to begin with an introduction from Karen. Karen, tell us a little bit about yourself and what you do at Geisinger.
Hi, my name is Karen Murphy. I'm the Chief Innovation Officer here at Geisinger, and I am the founding director of the Steele Institute for Health Innovation, where we work on all types of innovation, care model innovation, as well as digital transformation.
Excellent. Chris.
Hi, Shahid. Always great to see you. I'm Chris Ross. I'm the Chief Information Officer at Mayo Clinic.
Great. John?
Hey, it's John Holemka. I'm the president of Mayo Clinic Platform, but of course I used to be at Israel Deaconess. And Karen, remember, I used to work for Glenn Steele, but that was a generation ago.
And now Mayo has an unfair advantage. It used to be that John was not at Mayo before, and now they had one powerhouse, Chris, as a CIO, and now they've got John at running the Mayo Clinic Platform. So really unfair for everybody else, but really good for Mayo. So if you're getting care at Mayo, you're in doubly good hands these days. Peter, quick intro.
Yeah, hi, I'm Peter Pronovost. I serve as the University Hospitals Cleveland Chief Clinical Transformation Officer, and it's great to be here with my friends and colleagues on this panel.
That's awesome. Yeah, so let's talk about that first question that I posed, which is our health systems are going through a whole bunch of changes right now. And what do you guys think with respect to the changes that are taking place at the moment? What is good from an innovation perspective, because let's say things are happening faster and we can test things faster, versus what might be bad, like we're going to make bad decisions in the heat of the moment. So again, we'll start with Karen. Tell us, what do you see happening, good, mostly good or good and bad?
So that's a great question, Sid. And at Geisinger, I think what we've seen over the last 6 months is really, over the last 4 months, I guess it feels like 6 years, but what we're seeing is really an increased appetite for innovation. And it is very exciting, and it has been the silver lining of the pandemic. So we've seen the entire enterprise really willing to embrace innovation and actually seek innovative approaches to the problems that they're facing. So I think it really is a silver lining to what we've just been through.
Interesting. So Chris, do you agree with that, silver lining, or do you see mistakes being made more rapidly these days as well?
Well, both. I think there's the silver lining part, and we're definitely making mistakes. So, you know, we're still, unfortunately, very much in the COVID fight. We're in the, first inning, perhaps. A couple things, So, for instance, patients were offered virtual visits, and we have a chance to ask if they like them. I've seen a survey from a vendor that said about 72% of patients had their first ever virtual visit during this pandemic, and about 75% said they were satisfied with that visit, and about the same number say that they want it to be part of their care going forward. So clearly people are interested in new ways of receiving care, and we know from some previous experience that when healthcare is made into a consumer product, people like it. I think we've also discovered that people want a safe healthcare delivery system, and they want assurances of safety. So We know, for instance, that our patients are really pleased with the efforts we're taking to make sure that we're screening patients before they come. Everybody's doing that. It's the right thing to do. But we also know that people are foregoing care because they're concerned about coming into a healthcare environment and potentially being exposed to COVID. Will we continue to have that same level of concern? And I think the last thing is, I think we found out that healthcare as an industry was more agile and more resilient than we thought. We were able to do some amazing things, virtual visits, doing ICU isolation and better communication with patients and families, work from home. We sent 30,000 people home that weren't working from home previously. So we found out we could do a whole bunch of things, and maybe we're a little bit more agile than we thought. So to me, the big question is, which of the big problems in healthcare can we make into the next emergency so we take action on it around things like the AAA kind of goals, which haven't changed, around cost, quality, consumer satisfaction. I look forward to seeing if we can maintain this tempo.
Yeah, that makes sense. And that was a great point, Chris, that you brought up. We've heard for decades that, healthcare is too slow, but it seems like it's mostly too slow because we had no reason to be fast. So,
yeah.
John, tell us what you think about what's going on. Do you feel, and you've been a leader in this, in the digital health movement for at least a couple of decades, if not more than that. Are you happy with what you're seeing at this pace and wished it happened earlier? Or are we doing things differently that you don't like that are happening at this moment as well?
So I joined Mayo Clinic on January 1st of this year, and we developed a 2030 plan. It said, imagine in 2030, people are doing virtual visits and acute care at a distance and taking telemetry from remote patient monitors because we have the technology, regulatory frameworks and waivers, and a cultural expectation. The 2030 plan is now the 2020 plan. So as I think others have said, in the last 14 weeks, we have had such a radical shift in our capacity to deliver care at a distance successfully while maintaining quality and safety. But a whole lot of that hasn't been the technology. It's been regulatory change in waivers and reimbursement, but a cultural change. We are going to hold these gains, I am convinced, because our patients are now expecting this care to be delivered wherever they are in a convenient setting that is this device as opposed to heads and beds and bricks and mortar.
Yeah, and that makes a lot of sense. I think the biggest innovation probably at this time is the fact that we may understand that patient preference not only matters for surveys and things like that, but that the patient preferences should actually adjust how we deliver that care. So that's what we've, I think, done in this case. Peter, tell us, how much of what you guys are seeing in Cleveland have adjusted to what patient preferences are, and how much will this stick? Would you like what you're seeing so far? Anything you don't like what you're seeing so far?
Yeah, the resiliency and ability to innovate of the U.S. healthcare system has just been breathtaking. And I think it was a combination of three features of this pandemic: the urgency, the high risks, and the uncertainty that forced us to really live what I say the definition of innovation is ideas with impact. In the past, we focused more on the ideas and less on the impact. And we had no choice to rapidly make sure these things have impact. And how did that translate? Well, it translated into, I think, some simple things that were missing. Much greater focus on usability, where we would put engineers, or in the case when we stood up a home monitoring with the company and our clinicians, rapidly prototyping and being agile to get a product in 2 days, deployed, and making sure it had an impact, or we revisit it. As John said, much more digital and patient-centered, but fundamentally, which I hope we have time to go into, this pandemic has forced us to accelerate our journey towards value in ways we never have. Example, the estimates are 50% of ED visits could be cared for in a lower cost, perhaps even higher quality setting. What percent did ED visits go down with COVID? 50. Now, no doubt some of that was needed care. But probably the majority of it was consumers are more discerning and they got care in other places. We need to accelerate that. 30% of medical admissions may not be here. Medical admissions are down 30%. And so thinking of ways that this accelerates us with a vision of keeping people healthy at home rather than healing in hospital, I think is a trend that we're just beginning to accelerate.
Yeah, and I love that point. So if we extend on what John was saying a minute ago, which is we believe that many of these innovations are occurring primarily because of non-technology requirements, which is the, think about it from the, whether it's regulatory, some of it might be legislative coming up over the next few years. Let's dive a little bit deeper, Peter, into your point of how much more do we need to happen before we go to real focus on value? Since you brought up the topic, go ahead, Peter, talk a little bit about what would you like to see change to tie on value?
Yeah, so great point. And let me share with you a concrete example of how this is coming together, because what we're seeing also is we're really working as a system. And I don't mean just across the continuum of care, which we need to, but with payers and regulators and the tech company. A concrete example of how all the things that have changed. When COVID was hitting, we reached out to Massimo that had a mobile platform called Doctella that I was involved in, but I have no financial interest. They were supposed to make had made a disposable pulse ox, which you can imagine be very valuable, but it didn't have FDA approval. 2 days after the call on March 14th, we had a call at the FDA. They approved it on the spot. 4 days later, we launched our first patient. And in that interim, we had their engineers and our clinicians literally 10, 12 hours a day prototyping, writing work plans so we can deploy this. And a month later, a webinar with WHO where this was shared with 65 countries and like 3,000 health systems. And now I don't know how many customers they have on this, and there's many other vendors. The point was it required FDA approval. In addition, when we were going to scale, the CMS payment policies for home monitoring required 16 days of monitoring, which was longer than many of the COVID patients were because it was designed for chronic diseases. And to CMS's credit, they changed it now to 2 days. So you've had payment changes so you could have a viable business model, FDA changes, private sector changes, with health system collaboration that creates this ecosystem to make sure innovation has an impact. And that's what I was meaning when I said earlier about, I think we too often got focused on ideas and shiny new objects, not demonstrating that they improve value.
Got it. Karen, do you have some examples that come to mind that like this that you can teach other providers that they can do as well?
So I do. Shortly after we shut down at Geisinger, I began to lead the post-crisis work group. And the reason we did that is because we realized we were able to shut down the health system. And there were a lot of things that we stopped that nobody really missed. And there were things that we started, such as the work from home, virtual visiting, everybody really embraced. So 25 of us have been meeting weekly at Geisinger since March 14th, while the crisis was going on, saying, how do we transform our system going forward? And I think to Peter's point, the one concern I do have is if we don't get to value, I am concerned that the innovation is going to slow down, and that the way that we're pushing care to the home where our patients are and developing new care models outside of the heads of the beds, we need to be reimbursed. We need to achieve true value-based payment because it's not sustainable without that. So we at Geisinger have the health plan, so a good percentage of our revenue is already value, but really want to work with those other payers and support public payer in a payment innovation so that we can continue this work, because it is, John and Chris has said, the patients have really embraced, and I think we underestimated our patients. I think we thought that patients would not embrace the digital transformation to the extent that they have. Now, given the circumstances, certainly they want, virtual visits, I think, were promoted because of the fact patients were afraid to come in. But now they're comfortable with digital solutions. And I think working to enhance the care models that are supported, the transformative care models that are supported by digital, is going to be very important. But again, I think we have to stress that as an industry, we really have to figure out how we work with our public and private payers to move to value so we can continue this work.
Yeah, that's so important. So Chris and John, love to have the quick discussion. You guys have both have good government experience. Talk a little bit about how much can we do on our own without government assistance, meaning either legislative or regulatory or other means. John, especially, you're chairing the HCC 19 organization, which is a bunch of private partners. It's a big private partnership to do the kinds of things that the government was slow at doing with us. So let's have that quick discussion. I've been very impressed, and I think you've mentioned this in a couple of your remarks at the HCC 19 meetings as well, John, is that we could do this privately. We just never had, it looked like the reason or the rationale or the responsiveness necessary to do so. Do you feel like we have to wait for certain things on the government side? Certainly payments have to come from there, but what could we do on our own on the private side, led by groups like Mayo, to make things happen a little bit faster?
Sure. So I think ultimately you want a public-private partnership. It goes something like this. So the private sector can, of course, innovate and create new technologies, new data sources, situational awareness. We can deal with supply chain. We can do with coming together as a coalition so that we can redistribute resources across this country. But that inherently has limits. And that I think, as we've discovered in the COVID-19 Healthcare Coalition and Coalition of Coalitions, at certain points, you need regulatory waiver, you need the sponsorship of FDA and BARDA and ASPR and CDC and ultimately DOD, White House, Operation Warp Speed, and they all need to be aligned. And so the challenge, I think, is putting all those actors together in alignment with the private sector, but also creating guardrails. So we know, it's sort of a delicate topic, we're in an election year, and we want to really be guided by the science and the need and try to produce, some guidelines by which, as we put all these people together, that there aren't political actions being taken. And that's really what we spent the last week doing. The benefit of a public-private partnership, but guidance to ensure it's for the patients coming first.
No, and that's a great point, John. Just to follow up on that, though, what is your thought on the idea of convening authorities? One of the nice things, for those of us that have worked in government, is when the White House calls you, you typically end up going to the meeting, right? That's a convening power that they have. Who else might have this kind of convening power beyond just the government? And could we start to build that convening authority as a public-private partnership? So the mitre guys certainly do. The Mayo's, Cleveland Clinics, Geisingers of the world, they certainly do. How do we make the convening authority bigger and more powerful on the private sector side?
Yeah, and so to your point, this group of 1,000 companies has decided that the MITRE Corporation, a federally funded R&D organization, can be Geneva, right? It's neither a for-profit entity nor is it a government entity. It is a convener that has brought us together in a neutral forum. So that's worked pretty well. But I think, to your point, all of us here can also have our own convening functions. So Chris, maybe talk about some of the things we're going to be doing on data use ethics, privacy, and this new world where data for situational awareness has to be gathered from novel sensors, and we don't yet have a regulation on how to do it right.
Yeah, John. So I would tee this off of our partnership that we announced last September with Google, which was to do really two things. One of which was we needed a cloud provider to let us scale our own data and manage things the way that we wanted to, 35 petabyte of data that could be used for a lot of purposes. And the second was to join with Google to do innovative kinds of things. How many times 2 years ago, would someone say, why can't you find the details about my patient record? Wouldn't it be great if you could use somebody like Google to help you figure out where the data is? And that's exactly what we tried to do. But the challenge is going to be, how do you both pursue the idea of more cures for patients using data and also protect patient privacy? So we're trying to take a little bit of a leadership role in that. There's a lot of other groups out there like the Confidentiality Coalition and so on who are addressing the same kind of question. But we think that there's actually some technical innovations that might help, like the idea of federated search. One of our models is, don't send the data to the analysts, allow the analysts to place the data, their sensors in our data environment, which means data never leaves our world. Almost in every instance, it's dependent on de-identified data, those kinds of things that we think will allow us to use broader data sets to find more profound cures without having old models of untrusted central repositories or unknown commercial entities that are assembling data. I think that's very much a 2010s kind of thing. I think the 2020 view will be smart, sophisticated, science-driven methods to keep data safe, but to derive the insights out of them in a collective way. And I'm super excited about what we can do in that space. And we're trying to really push the frontier. So we know later this year, we're going to try and convene a number of people around that question and try and develop some best practices.
Yeah, that sounds fantastic, Chris. So do you think that what you just said is primarily possible because you're Mayo and you've got that credibility and authority in the industry? Or do you think that based on what you've learned, others can do it within their communities, within their states, because all healthcare is local? Can they do it? And what would you recommend that they do?
Well, I think Mayo's in a unique and privileged spot, and it's really quite a privilege to work at a place like Geisinger or Cleveland or Mayo. And so I think it really, and many others, it's incumbent on us to try to lead. In my view, I think, for instance, just to tie back to the remarks that John made, I think government actions in some ways is necessary but not sufficient. A lot of the things that we're finding is where the government needs to potentially step out of the way. John used the word waiver a whole bunch of times, which I think is totally appropriate. I think that what we will see that will persist out of where we are is a little bit of the consumerization of healthcare in pursuit of value in the way that Peter described it. And I think we've got models from the past of where when healthcare tried to be more consumer oriented, we got more change than we did with lots of large institutional kind of consensus or government driven kinds of things. So I'm a believer here that some private action, entrepreneurial action will be one of the most important forces that we'll see come out of this era.
Yeah, and when you think about the way that a lot of large institutions have operated with the government in the past, it's been that they try to influence the government, but the government is still expected to lead. And let's talk about that topic just very briefly, because there's the idea of influencing, and then there's the idea of leadership. Leadership is for people who actually get stuff done, right? They have projects, they have people, they have teams, and they have a direction, and then people go towards that. Influence is telling people, hey, you should go in this direction or you should go in that direction, but you're not really responsible or accountable for almost anything. And so it seems to me we are probably in a good spot over the next 10 years to swap that and say, you know what, maybe the government is doing more influencing and we don't look to them for true leadership. We in the private sectors and the private communities where we are dealing with patients on a day-to-day basis, we do the leading and let others do the influencing. Does that sound silly, or does that sound like a reasonable thing that we can do based on what we've learned, Karen and Peter? Maybe Karen first, and then we'll let Peter jump in.
So I think it sounds very reasonable, and I've had experience working on both the federal and the state government, and I can tell you policymakers are definitely open when it's presented in a way that is effective. I did want to make a comment, though. I think one of the reasons we were successful, all of us, the whole healthcare industry during and as we are still in COVID, is because it was a singular focus. And one of the things that we've discussed at Geisinger over and over again is how effective we all were, because we were all marching in the same direction because it was a focus. I think the industry has to work with policymakers to develop a much more focused approach, and really, instead of trying to boil the ocean, let's pick the problems that we have, focus on all of the convening, collaborating, but focus on solving those problems instead of just saying, we're going to boil the ocean and we're going to transform the healthcare industry. We've tried that for the last 10 years and it has not worked. So I think, again, taking a lesson from our COVID experience and saying what we are capable of when we focus, if we could collaborate as a healthcare industry and identify what the focus should be, and then work with policymakers, maybe we need to take a step back and solve a couple problems instead of trying to solve all the problems at the same time.
Yeah, and if you think about that, Peter, goes to what you were saying a minute ago. So let's imagine that the four of you went together to the FDA or any bodies where you wanted, actually probably to CMS or CMMI, with respect to value. So let's say that the convening of private parties was occurring, just like we're having this discussion here. That now we were going to go and make a case to CMMI for value. What would that case look like? What would you say to them if you had the leaders at the Centers for Medicare and Medicare Innovation sitting in front of you? What would be the one or two things you would ask them and say, look, if you just put this waiver, as John said, or added this new regulation, this would allow me to do 100 more things. So if we did what Karen was saying, which is focus on a few key things, would those key things be what John mentioned a minute ago, which is a continuation of the idea of regulatory changes, or would it be something else? What should we ask for at this point to make innovations go faster?
I want to start with that. So you know that I do 900 telemedicine consults personally a year as the nation's expert on poisonous mushrooms and plants. And you know that before 14 weeks ago, because I'm licensed only in Massachusetts and Minnesota, I couldn't actually do patient advice in North Dakota, even though I am the world's expert. I had to find a physician in North Dakota who would then listen to me and decide whether I was credible or not. Well, that has changed, right? So the idea that it doesn't matter where the expert is and the patient is, and that you can deliver these services, that was absolutely key. Bringing parity to reimbursement of whether it's an in-person or a remote visit, that was absolutely key. But there are other scope of licensure questions. So 2 weeks ago, Mayo went live with acute care in the home, our advanced hospital care in your home. And of course, we have various kinds of licenses, nurses, nurse practitioners, paramedics. So, hey, Shahid, where can a paramedic practice? Can a paramedic deliver services in your home? Oh no, they can put you in a truck and take you to the hospital, but they can't deliver care in your home, right? And so this notion of looking at each person in the value chain, looking at practicing at the top of their license, removing geographical restrictions or site of service restrictions, and bringing parity to reimbursement is essential.
Yeah, great point. And Peter, you want to extend it? Peter, we can't hear you. And your mic on mute.
Yeah, I sure would, because I think this conversation is so critical. And I would add, not only could the private sector lead in this, we must, and the federal government is looking for leadership. And all these examples, they responded to demands from clinicians. But let me perhaps reframe this, even thinking more like an engineer, that the need for innovation is profound. I mean, we are the only industry that has negative labor productivity despite spending crazy amounts on IT. We still have medical error as the third leading cause of death. We still have half the patients getting the recommended therapies. And what I would love to see, and what I'm reflecting on, is thinking of some health systems coming together in a value alliance that would laserly focus where are these defects in value that are causing the most decrement in value, and finding solutions for them. Now, to do that, we need to create incentives for the manufacturers to work with health systems, because they often battle over IP. That's a solvable issue. We need much better usability, like I mentioned with the Massimo, and we need a way to have that selling to your first 10 customers, but this idea of a value alliance of health systems coming together, I think could really solve that. Of course, we need payment models that provide it, but I think where we need to start framing our mind as an engineer is it's not just telemedicine, or even in my case, the monitoring at home. It is the defect is we are caring for people in a higher cost, lower quality setting in the hospital or the ED, and let's put it in somewhere else and measure that impact. Another kind of example is, you may know, nurses spend 24% of their time hunting for supplies. It's absolutely ridiculous that if there's technology in 10 other industries that have solved it, but we don't, and it's really expensive. Nurses spend 22% of their time answering false alarms. And I think in part because we haven't approached innovation like an engineer to say, where's the defect in value, and a framework for that, and then going back and designing a system that addresses that defect and then scale it across the industry. I'm confident the federal government is looking for examples like this. And if you go to them and say, hey, I just reduced hospital admissions by 30%, or your per member per year spend in Medicaid by 15 because I did this, we don't have to worry about the payment model because we'll have the evidence to support it.
Interesting. Does everybody else agree with that? Karen, do you agree that Peter's optimism about how fast the feds will respond based on your background is likely to happen?
I'm cautiously optimistic. I think we look at the government and the inherent bureaucracy. Again, I think to Peter's point, if we could, I do believe they would be responsive if we were focused. If the healthcare industry said, we want to come together to figure out the 50% decline in ED admissions. Geisinger, we're looking at this right now. What were how did we, not only was it concern on the part of patients not to come in the hospital, but what interventions would be successful in taking a look at those patients that, to Chris's point and everyone's point today, not those that really needed care that didn't come, but those that really didn't need to be in an ED and did not suffer adverse outcomes. So if we were to say, this is the problem we want to solve, these are the regulations that we want relaxed, or the policy changes that we want to support, I do think that they would be responsive, because CMMI and state governments have been working on lowering healthcare costs and trying to improve quality for over 10 years. And I think we have to be open to new ways of approaching the public sector, and also our convening. I think we have to look at the industry, at ourselves, and say, where did we, it isn't just the government that wasn't successful here, it was the industry as a whole. So how do we take a look at ourselves and change our approach so that we can be more effective to achieve those goals?
Yeah, I really agree with that.
I would just add, I spent the last year as a government employee as an advisor on value to the deputy secretary, and one of our works was, presenting this healthcare quality roadmap that was just recently released. But I can tell you, I was heartened over and over again, where if there was an idea that added value, they were hungry to hear it.
Mm-hmm. Mm-hmm.
So I agree with the comments made, and I think it would be fantastic if we had great alignment amongst the provider community and alignment with the government. That's great. But I would say two things. One is we shouldn't wait for a consensus to emerge or the government to lead us. And the other parties we haven't talked about is the unknown innovator who's going to enter this space. So the closest experience in my career I've ever had to COVID is in 2006, I joined this little group called Minute Clinic, which was trying to invent basic healthcare in a drugstore or a grocery store. Within a month, CVS had bought us when I showed up there. And we went from 45 clinics to 600 clinics in 8 months, which was the same kind of pace of change. And that organization was really helpful. And it proved that you could do high quality healthcare for admittedly a narrow range of services and move healthcare in some significant ways. And it's still an important part of healthcare, delivering care in retail care or urgent care. but I think many of us who've been involved in that would say we fell short of our highest aspirations. And part of that was, don't underjudge inertia, both positive inertia, when things change and people want something and it becomes a movement, that's positive inertia. But there's a lot of negative inertia in our industry as well, too, that gets in our way. So I'd say a couple of things, one of which is let's just do it and not wait for somebody to clear a road for us. And second is, I think that some of the best ideas are not going to come from government or from the payers or from the large or established providers. I think that there's a terrific aperture here for innovation coming from new companies who are going to do something that we may scoff at as not being good enough, but you know what? It'll turn out to be even better than what we already have.
Right. No, that makes sense. And John, tell us a little bit about, given that you've implemented many technologies and you've got the MD background as well, what do you recommend to innovators today for them to think differently based on what's happened with COVID? Now that regulatory burdens are getting removed faster, the cloud is here to stay, and no healthcare system in their right mind is looking at this and saying, well, I'm not sure if we're going to go into this cloud thing or not. I mean, you're going to either go to the cloud or you're going to die a horrible death very quickly. So that's taking place. The amount of tech available to do building is increasing. How should innovators change outside so they can move things faster on the inside?
So Chris actually set this up very well, which is you think that the next disruptive innovation is going to come from a giant monolithic organization? Probably not so much. It's going to come from two guys in their garage. So the question is, how do you set yourself up to rapidly adopt that innovation that comes from the two people in their garage? And this is really what the Mayo Clinic platform idea was, which is work with Chris, set up your cloud-hosted, de-identified data sets, ingest signals from wearables and the devices in your home, set up the processes by which you can deliver care in all kinds of settings, and then embrace these collaborations and partnerships with all these startups and bring them into the ecosystem. And so I think it's just really important that cloud first, fire enable ecosystem of innovation, especially with small disruptors, will be important, in fact, essential over these next post-COVID quarters.
No, interesting. So in the previous sessions, I brought up this idea that actually listening to patient preferences is an innovation. Maybe to say a different way, what you're saying is, if the hospitals and health systems that are going to consume these technologies and innovations can just focus on innovating their deployment capabilities, everything else on the outside will take care of itself. Is that what you're thinking, John?
Well, so for example, let me just come up with something. The Department of Neurology at Mayo Clinic said, we think we could diagnose neurological disorders from Alexa. And I don't necessarily mean Alexa. I mean the notion of listening to the way someone speaks. Mm-hmm. It's like, oh, that's a disruptive idea. How long would it take a traditional healthcare system to put that in place? Oh, we'll wait for the EHR vendor to come up with this or that. And it's like, no, get a couple of folks together, get a pilot going, try it out, see how it goes, and then inform the world. And be able to do that in a cycle time on weeks, not months to years.
Got it. And Peter, it sounds like that's what you guys are doing. You're not waiting for anybody to come in. You're saying that as soon as the tech is available outside, bring it in, let us help you move this inside, and we will work with policymakers to move things along. You took the responsibility, sounds like in your example, Peter, to make the call to the FDA with Massimo, not letting them say, no, come back to us when you've got everything solved. Does that sound right?
Yes, that's exactly right. And Massimo is a great partner, but I would just frame that as I think it needs to be bi-directional. Yes, I totally agree. It's going to be either other industries that are bringing technologies that have worked there, like this last tendency to supply chain to healthcare, or startups, but also we need to be much more vocal of a call for needs to say, for example, nurses are wasting all their time double checking medications or answering false alarms. Tech, figure out a solution for that. I guarantee it won't be the big monolithic companies. Right. It'll be a couple young kids, but we need to have tech focused on solving laser problems that are reducing value in healthcare.
Yeah, that makes sense. And so we're in the last minute or so of our discussion here. Karen, we'll start it off with you. We'll let you kind of take us home here. Talk to us a little bit about what should one or two things that a health system do to prepare for outside innovation to enter your environment and be able to then use it.
I think we have to take a look at our own inherent complexity and be willing to welcome that disruptor into the healthcare delivery system. So part of our issue is, before COVID, I would say, is waiting for the EHR vendor or making the list of 7 committees that it has to go through. I think we have to welcome the disruptor. And I think not only do we have to welcome, we have to proactively, to John's point, go look for the disruptor. So go and I clearly identify the problem. We at Geisinger define innovation as a fundamentally different approach to solving a problem that has quantifiable outcomes. So we don't look at anything that is not a problem. But I think we have to clearly identify the problem and then not look within, our own box, but actually look for disruptors to come in with a fundamentally different approach.
That's a fantastic way to close this out. And I do really appreciate Peter, John, Chris, Karen, all your advice.